Good evening, everyone. Welcome to this Spine Tuesday session organized by EUROSPINE. My name is Thibault Remacle. I'm very pleased to moderate tonight's discussion, which will focus on one of the most rapidly evolving areas in spine surgery, endoscopy. So today's session is designed as a practical and honest comparison between two approaches, monoportal technique, who will be presented by Dr. Siepe, and Biportal, who will be presented by Dr. Cristini. The goal is to help surgeons who are considering starting endoscopy to understand the strengths and limitations of each technique, and most importantly, to share tips and tricks for safe and effective start. We are very lucky to have two highly experienced surgeons who will share their experience tonight, and I will let Dr. Siepe introduce the monoportal technique. Thank you.
Thank you, Thibault. I'm trying to share my slides here. Did you go out? Okay, here we go. All right. Thank you, Thibault. Thank you, Joseph. I'm really looking forward to doing the session here tonight with you. Thank you, everyone, for joining the session. So I work with the Monoportal full endoscopic technique. My personal background is a microscope. So I will tell you about some of my experiences. And really what we're trying to do today is talk about the indications, so set up the first cases, and so that you get a good idea how to work with the endoscope. So these are my disclosures. I'm a consultant for EUROSPINE, and my personal background is the microscope. So I have grown up with a microscope, and I think the microscope is a very good tool. Okay, so I think as surgeons, it's always good to have a big toolbox that we can choose from, because there's no technique that is always the best. Sometimes you need the microscope, sometimes you need the endoscope, sometimes we need to fuse, sometimes we need to do an ALIF, an OLIF, whatever, disc replacement. So it's very important to have a big toolbox. And when we look back 40 years in the 80s, coming from open surgery, there was a huge advantage going from open surgery to microsurgery. Much smaller skin incisions, and you have less tissue trauma, a much better visualization of very delicate neural structures. You can control bleeding better, and so all the secondary positive effects, shorter hospital stay, less complications, and so on. So I think the microscope is a very good tool, and nowadays this should be considered a gold standard. And for the same reasons, going from open to micro, we hope that we can get a further benefit when we go from micro to endo. So this is an overview what the endoscopic setup looks like in our OR in Munich. So you can see we're doing all of these surgeries and everything is displayed on nice 4K displays. And this is one of the learning objectives today. I think it's very important to actually establish what are we talking about. What are the pros and the cons maybe of the monoportal, of the biportal? And sometimes these different terms are used synonymously. So what I'm talking about is not micro endo, that's actually micro and it's not endo. I'm not talking about tubular systems. Some surgeons say I also work endoscopically, I work with tubes, but that's not full endoscopic. That's just a tube, another type of retractor. I'm also not talking about anything endoscopically assisted. So what I'm talking about is the full endoscopic surgery with a uniportal approach. I'm telling you my honest opinion up front. I think the uniportal and the biportal approach, the only thing they have in common is the word endoscopic. But otherwise, there are huge differences between the two techniques. And obviously, my personal favorite definitely is the uniportal approach. For a number of reasons, and I will talk about that later. So just to give you an idea, we make a small skin incision, let's say 8 millimeters maybe, depending on the type of endoscope that you use. then right from inside the spinal canal. So now our eyes are not outside the spinal canal. We don't just zoom in. Our eyes are inside the spinal canal, and we get perfect pictures on our HD or 4K screens. We can do our surgeries, and then this is how we can finish the surgery with just a single stitch suture. So very nicely, very elegantly. And now we have different types of pathologies that we want to approach, and then we also need different types of approaches. So the most common ones are the transforaminal approach from the side, the lateral approach, that's a transforaminal approach. There is the extraforaminal posterolateral approach, and the interlaminar approach. So we have different approaches that we can choose from, and there is no approach that is best. I will get back to this later. So let's say, for example, we want to decompress spinal stenosis. Then these are the structures that need to be decompressed. We want to remove the hypertrophied yellow ligament. I'll show you some OR videos just now. We want to remove the hypertrophied part of the facet joint. And that you cannot address with a transforaminal approach. I don't know if you can see my cursor here. So you can address this area, the foraminal and the extraforaminal space. On the level of the disc space, you can get inside the spinal canal also, and even to the contralateral side, but you cannot address the central part of spinal canal, and you cannot go over the top. Otherwise, with a transforaminal approach, you would have to go through the dura. So technically, this is not possible. So for an over-the-top decompression, we would have to choose the interlaminar approach. So which means at the end of the day, that depending on your pathology that you're trying to address, you will have to change the approach in accordance with the underlying pathology. So we have different approaches, and then we have different endoscopes that we can choose from. We have longer endoscopes for the transforaminal approach. We have shorter endoscopes for the interlaminar approach, varying sizes, 3 millimeter, 4 millimeter, 5.5 millimeter working channel. It doesn't sound like a lot, but in practical terms, it's a huge difference. So for example, if you want to do an over-the-top decompression of advanced spinal stenosis, where we have to remove a lot of material from inside the spinal canal, then this is the endoscope that I would recommend. 5.5 millimeter working channel gives you a better, you can insert larger instruments. You can see here you have 2 channels for irrigation to get rid of all the debris. So different tools that we can choose from, different approaches that we can choose from. And you can see already here, when you look at the design of this endoscope, there is no need for a second portal, for a biportal, because the camera is included here. So in the biportal technique, the second approach is only to insert the camera, which here is included. So there is, from my point of view, no need for the second skin incision. The next thing that you can see here is, and I will get back to that later, the endoscope is ovally shaped. And this is very important because in many biportal systems, when you use an arthroscopic system, sometimes depending on the system that you use, there is a risk that you put in too much water pressure into the spinal canal, okay? And this could even cause neurological complications. So it's very important. I'm working with the endoscope that you can see here on the right side. So the endoscope that you can see here is ovally shaped, but the working sleeve is round. So what you can see here in red is a space between the endoscope and the working sleeve where there's always an outflow of water. This is why the endoscopic system that I work with, it's called an open design system. There is always water flowing out. And that's very important, this cannot be stopped by the surgeon. Okay, so you will never get this excessive risk of too much intraspinal pressure. So this is usually one of the questions that comes up in these type of presentations. So very important. Another advantage as opposed to biportal, where you may have the risk, depending on the system that you use, of too much intraspinal pressure. Here, there's not too much intraspinal pressure because we work with an open system. The next advantage is we get very good visualization, and I'm working with, depending on the endoscope, 20 to 25 degree angled optics. and you can actually look around the corner, like with a periscope of a submarine, which means you can use this tool very nicely. Okay, so you can look underneath the cranial lamina, look for a sequester there. You can follow the nerve root caudally, look under the caudal lamina, or with a 20 to 25 degree angled optics, which is a very nice tool. And many of the biportal systems work with 0 degree optics. So that's also another technical discrepancy. Otherwise, what other tools do we have? When I work with the uniportal technique, we have burrs, we have sharp burrs, we have diamond burrs. I basically do everything with the burr that you can see here on the left side. Everything really. Actually, I do all of my surgeries with just 4 or 5 tools. That's it. Small Caron, big Caron, the burr, the bipolar, and maybe a dissector. And I do all the surgeries with it. So there's a lot of instruments that you can purchase. But actually, I'm doing all of that with a very small set of instruments. You can see here, there are the scissors. We can get Carensons, small Carensons, bigger Carensons. So anything really that you need. There is a bipolar. That's a very important tool. The bipolar. Wait, I think I have to go back here. Doesn't let me play it. Okay. The bipolar is very important because you use it to palpate, you use it to mobilize the nerves, you use it to stop bleedings. And the next thing that you can see here is now I'm showing you a short video with the scissors how to open the yellow ligament. Let's say you have a disc herniation. If I have a disc herniation, I try to make only very small incisions into the yellow ligament, and then you can leave the rest of the yellow ligament intact, which is very important because then this actually prevents scarring. So you can see here, this is the time that it takes to open the spinal canal. Okay, so you do this quite quickly. And you can see this, I only make like a 2-3 millimeter incision just over the nerve root. So this is the nerve root. Everything else is left intact. Obviously, this is differently. When I do spinal stenosis, I remove much more of the yellow ligament. Actually, everything, you try to remove everything for spinal stenosis. But in a discectomy case, I only really sometimes make very small incisions right over the nerve root, just enough to get into the spinal canal. And this is also less invasive in my eyes than what you can do with a biportal technique. So just a comparison. So I told you about some of the technical tools that I have. I personally think the invasiveness is less. I only have 1 incision, not 2 incision, that you have with a biportal technique. With a biportal technique, you need to create a cavity in front of the spinal canal. So you need to remove much more of the tissues there. So I think the invasiveness of uniportal is definitely significantly less than biportal in my eyes. There are different radio frequency systems. So for example, I work with a 4 megahertz system, so which means the heat is really right there only at the tip of the bipolar, whereas many of the arthroscopic systems, they work with 300 kilohertz systems. So there is a risk of more thermal spread. Okay, so my thermal peripheral heat is very located only right there where I use it. I told you about the fluid management system. I think it's safer that I work with an open system in comparison to working with more water pressure. Then there is another issue. I think, for example, if you do something in the foramen or extraforaminally, there's only very limited space. I find that safer when you do this with only a single instrument instead of having to put 2 instruments into this limited space. But Joseph will be able maybe to tell us how you work, Joseph, with a biportal technique in the foraminal space. I think this is maybe a bit more tricky and maybe a little bit more risky, putting in 2 instruments into this confined space. Other things, many of the biportal surgeons tend to always work from the same side. So let's say you're used to working only from the left side or from the other side, okay? But I think it's very important that you alter the side of approach if depending on the patient's side of complaints, if the patient has more left or right-sided complaints, if there is a rotation in the spine, if there is tilting in the spine. So for me, it's very important that I can always change between the left side and the right side. And I think it's actually a very crucial part of preoperative decision-making. So there are also, you're more flexible with a uniportal technique, I think, than with a biportal technique. Okay, so there are, I think, many technical issues. Okay, so uniportal technique, how do I do the surgery? This is the first part, first day of the beginner's course. This is how to hold the instrument. Very important, okay? And there is maybe a downside of the uniportal technique. The handling of the instruments is different, and there is a learning curve associated with, working with the uniportal technique on a very confined space, okay? And you need to give yourself time to learn this, okay? And then the second advantage maybe of Biportal is that it's cheaper because you may use old arthroscopic systems that you already have, but otherwise I really don't see any advantage of the Biportal or the Uniportal. This is a perfect beginner's case. This is where you should start. A fresh disc herniation at the level L5S1. There you have a wide interlaminar window. You don't need to work with a burr yet. So this is a very easy beginner's case. And this is what I would recommend to start with when you want to learn the interlaminar technique. I'll show you how to do discectomies, sacrohysterectomies. I'll show you a number of cases. This is a tricky one actually, because you can see from the pictures, the disc herniation is located in the axilla. So it's a little bit more challenging. Okay, so you can see here, up here, there's the dura. Around about 6 o'clock, there's the nerve root. You can see this is the axilla. First of all, I always try to go from lateral underneath the nerve root and see if I can grab the disc herniation from there. I try. If it's not possible, well, then we have to go through the axilla. And this is what I'm doing in the next step. What I want to show you also is you get a very, very good visualization of the neural structures, okay? And this makes this interlaminar technique very safe. You see the neural structures, that means you can protect them, okay? So then we take out the disc herniation, we take out this big fragment, and then at the end of the surgery, you finish with just a single stitch suture. But you can see here, everything's fully decompressed. I mobilize the nerves. I make a decision. Do I maybe need to go into the disc and do a discectomy, or can I only do a sacrohysterectomy? And otherwise, if I think that everything has been fully decompressed, then we can finish the surgery like this. So this really, in my eyes, is the most elegant technique that you can do. It's maybe not, maybe there are cases where you say, okay, maybe I still do this with a microscope, but otherwise uniportal endoscopic for me really is the most elegant technique for a number of reasons that I have already outlined. Sometimes we need to do spinal stenosis decompression. In those cases, for spinal stenosis, I really want to remove the entire yellow ligament, okay? Because this is part of the pathology. And my strategy here is similar to how I do it when I work with the endoscope. I go all the way cranially to the cranial lamina. I detach it from there. I pull the yellow ligament down, and then I start resecting, like you can see here. I start with the scissors. Then I start with the small Kerenson. Now you can see the apical fat tissue coming. Once I've done the central decompression with a small Kerenson, then I will start with a bigger Kerenson, which is actually 5.5 millimeters. So it's actually quite a big tool. Okay, you can see the dura coming here. I start with a central decompression. Then I continue later with the ipsilateral recess decompression that you can see here. So again, you can see this from this video here. You get a very, very good visualization of the neurostructures. And then you can see that we have decompressed everything. So I think in this video here at around 3 o'clock, 4 o'clock, I would still remove this. Once I've done the full decompression, then we go over the top by tilting the endoscope. And that's actually an easy part of the decompression, to go over the top. You can use the scissors for this. You can use the big Kerenson, the small Kerenson, the big Kerenson. You can see again with the 25-degree angled optics how I'm looking at the tip of the tool. Okay, and then you do the over-the-top decompression, like you can see in this video. Post-operatively, patients are mobilized immediately within 2, 3, 4 hours after the surgery, as soon as the patient feels fine. In Germany, because of our reimbursement system, they have to stay for 48 hours, because if we do it same-day surgery, outpatient on an outpatient basis, or if the patient goes home after 1 day, they will deduct 30 to 40% of our reimbursement. And that's why the patients stay for 48 hours, okay? But otherwise, medically speaking, there's no reason You could do this on an outpatient basis easily. Okay, and then you can do advanced stenosis cases like this. And this is the end of the surgery, what it looks like. So I can show you here. This is at the end of the surgery. I take a screenshot. Looks good. Okay, and then you can also do big synovial cysts. We have the usual problems. Maybe sometimes they can be very adhesive, but you can do this also. And then what I very much like is the posterior cervical foraminotomy. Okay, so small incision in the back. Okay, then you can see the exiting nerve root. We take out the big fragments. Okay, and then you can see the nerve root. The nerve root is fully decompressed. And then you finish a surgery like this. And also when you have big patients, maybe with skin like this, obviously much better for wound healing than when you have to do an open incision there, for example, with a microscope. So this, for me, is one of my absolute favorite surgeries. And the risk of bleeding is so much less here also with the endoscope than if you do this with a microscope. And it's actually truly minimally invasive. You have motion preservation because you can still preserve the disc. So in cases where you can do the endoscopic posterior foraminotomy, I really recommend it. But it comes much, much, much later in your learning curve. That's very important. So what can you do with the uniportal technique, with the endoscope? You can do disc herniations, you can do recurrent disc herniations, you can do revisions, you can do cranial sequestration, caudal sequestration, you can do spinal stenosis, you can do synovial cysts. So basically you have burrs, you have scissors, you have all the tools, you can do all of these pathologies. So the question, if you can do this or that pathology, is not so much a problem of the endoscope. It's much more a decision that you have to make for yourself. Do you think this is a case that I can treat properly with the endoscope at my stage of the learning curve? Or maybe not yet. Maybe I keep this for in a year's time or in 2 years' time. So the technique is not the limit. Really, the learning curve of a surgeon is the limit. And you have to make a conscious decision if you do the endoscope or if you choose the microscope. And that's why when you start working with the endoscope and over time, there is like a blending phase. In the beginning, you do most of your surgery still with a microscope and only very selected cases with the endoscope, the easy cases, which is important to do that. Start with easy cases, please, okay? And then you take your time with your learning curve, and then over time, you will see yourself doing more and more cases endoscopically. So why should you do the learning curve? What are the advantages? The microscope has a very good visualization. I think it's a very good tool. I think everybody should be able to work with a microscope. But the visualization with the endoscope is even better. We don't zoom into a picture. Our eyes are actually right inside the spinal canal. And now here in this video, I'm really exaggerating, okay, just to show you what's possible. I'm basically flying towards the axilla of the nerve root. You would never be able to do this with a microscope, okay? Microscope is a good tool, but the visualization with the endoscope is even better. Everybody wants data. There is so much data out there nowadays about the superiority, or at least it's non-inferior. And, you know, with meta-analysis, we have everything that we need. And some of the authors actually say that the endoscope will take over as the gold standard maybe for the discectomy in the near future. For me personally, I think one of the hugest advantages is for obese patients, either very big patients, okay, or very obese patients, because for me, it doesn't really make a difference if the patient is 50 kilos or 150 kilos. You make a small skin incision, then you take your endoscope, okay, you put it in a little bit deeper, but actually doing pretty much the same surgery. And then when you have a patient, 140 kilos, and you can finish the surgery with just one single stitch suture, this is super elegant, okay? Much less risks of infection, wound healing problems, and so on. And then you can do the surgeries. Single level, you can do multi-level surgeries. Obviously not. If every level takes you 2 hours, then you still need to, you know, need some more practice. But you can do all of that, okay? And then the wound heals like this within days. For me personally, you know, when you work with a microscope, you make your incisions smaller and smaller and smaller because we are all very enthusiastic to make small skin incisions. but you get to the limit of what you can do with this technique. And then sometimes we find ourselves making small skin incisions, but putting a lot of pressure on our retractor, okay? And then you get this. So you don't have that with the endoscope, with the uniportal technique, okay? There's never any pressure. You make a skin incision. There's always no pressure on the skin here when you work with the endoscope. You have many liters of saline solution. So if there's no open wound cavity. So I'm not telling you any romantic stories. You can have complications. You can have dural lesions. You can have epidural hematoma. You can have bleedings, recurrent disc herniations. But the risk of infection or wound healing problems with the uniportal endoscopic technique is virtually almost zero. There's never zero in medicine, but this is as close to 0% as you can possibly get. So the risk of infection, wound healing problems, basically like that for a vertebroplasty or kyphoplasty, so extremely low. So these are a number of advantages that I see for the uniportal technique. Okay, there is a learning curve, no question about it. Please take your time. I really think that it's worth it for a number of advantages of this technique. The transfemoral approach is a little bit easier from a manual point of view, but the anatomy is a little bit, we have to get used to the foraminal anatomy when you start with that. The interlaminar approach is more difficult from a handling point of view, but at least the anatomy is what we have grown up with, okay? But still, there is a learning curve. Take your time, easy cases in the beginning, and then you take it step by step, okay? But then I can see many, many advantages over the microscope and also over the biportal technique, as I've pointed out in my presentation. So many advantages. Good luck. If you are interested, we're always trying to, give you tips and tricks, and we have many, many things out there on the internet, on YouTube and videos, and we try to provide guidance. You will find this here. Easy videos, like maybe 3 minutes, 4 minutes, 5 minutes, something easily digestible. So I hope there's something here that you may find useful too. So thank you very much to everyone again for joining this, and I'm looking forward to hear Joseph's presentation and to getting a lot of questions from your side. Thank you.
Thank you, Christoph. It was really clear and very nice. Now we will hear about Joseph Cristini from Marseille, who will discuss biportal technique. Thank you, Joseph.
Thanks, Thibault. Thanks, Christoph. I don't know if you can see my screen. That's okay.
Yeah.
Okay. Hello, everyone. Difficult to speak after Christoph because it's a big master. I will try to speak about the unilateral biportal endoscopy. Another one technique. I will speak about your journey. We will have this kind of plan with just speaking about UB revolution, something Christoph spoke about, the water and the pressure, the equipment and the setup you need, the learning curve, the step-by-step technique, some tips for the complication management, some case selection, your path forward, and we will speak just very fastly about some other topics. The UB revolution. What is UB? UB is a unilateral biportal endoscopy. You have two portals. In one portal, you can have your endoscope, your camera. You can create a crystal clear field, and you can see a lot of structures, and you can swim in this small aquarium you can create in the working space, and you can find some familiar logic, like in knee, in shoulder, or in a mini open or open surgery, because you will see we will have the same instruments like we have in open or mini open surgery. We have two portals, and thanks to Christoph because he introduced a little bit the UB, and we will speak also about the standardization we can do. Christoph spoke also about the less and mini incisions. Where UB stands, you can have a panoramic view with the same instruments. You can have a very low traumatism for the tissue, an excellent bleed control. The learning curve is moderate because you can find some very common gestures you can have in open or mini open. The cost of the materials is very important, and you can have sometimes some materials in your institution, and it's really easy to use it. And you can also extend your indications, and we will see that. Just for the water pressure, because it's a new surgery, it's an aquatic surgery, you have to be humble and to have a good formation. And for that reason, you have to manage all the setup, and you have to know this is important to manage the water pressure. The ideal zone of the water pressure is between 30 and 50, but it is in lumbar, and we will see some differences in thoracic and in cervical. Less than 20 is too low, and if you have a big pressure, it's very dangerous. You can use an arthropump or gravity setup. What is essential is the outflow. If you have a good outflow, you can't have an hyperpressure. It's the most important at the beginning. It's to manage the outflow of your water. If you don't have a good outflow, you can have an increasing of your bleeding, and be careful because yes, you can have some complications, but you have to know all of that before. The ideal zone is between 30 and 50, and we will see some specification with the arthropump. For the equipment and setup, you can find on this article from our center, our institution, from a smart neurosurgeon, Aurore Cellier, how to begin unilateral biportal endoscopy, and you will find a lot of tips and how to standardize your technique. The setup is very simple. You can have a column with a classic spine box instrument with Kerrison, disc forceps, and hooks. The column is an arthroscopic spine column, and you will have some just specification. It's a radiofrequency generator, arthropump, and shaver generator, and you can use some drapes from gynecology, some cesarean section drapes. In our center, we decided to standardize always the surgery, and we always stay at the left side of the patient, and we will see after. When you want to introduce this technique in your institution, you will have the approbation of all your team, and it's important to have some standardization. It's always the same. You can see my nurse assistant with their hands on the legs to control. This is an artisanal monitoring to avoid some neurotoxicity. The operatory condition, it's a normal position with a proclive 10 degrees. We have to control the blood pressure. You can have a catheterization at the beginning when you create the working space, and after you have to put a water pressure between 30 and 40. You can add some adrenaline in the two first saline bags, and you can add tranexamic acid in intravenous during the surgery. The essential UB arsenal, we spoke about that. You can use a 0 degree or 30 degrees arthroscope, 4 or 5.5 millimeter, depend of your level you want to operate it. With a camera system, you can use Kerrison with 2, 3, or 4 millimeter, like you can use in normal surgery. You can use a shaver or speed drill. It's better to use a shaver because you can have a security. It's safer to begin, and you can use a bipolar RF probe, and you can change the parameters to avoid some neurotoxicity. For the access, you can put a dilatator to maintain a good outflow, and you will have a working sleeve with irrigation port. And the most important is, after we will see that, is to find the docking point, the junction between the lamina and the spinal process. It's a landmark marking on the skin to begin and to imagine your triangulation. The irrigation, you can have a gravity or a pump. The better is to use a pump with a retro control because you will have a stable pressure during the surgery. In UB, water is your scalpel because you can have some water dissection, and it can help you when you have some adherences and on the stenosis in lumbar or in cervical. The learning curve, it's a new cockpit. You have to manage first your environment, the installations, the pedals, your ergonomy, and you have to learn about the endoscopy, and we spoke about the water pressure. So the learning curve, you have to begin. First, you have to have a good formation, and after that, when you will begin, you will be long, but it's normal. You will have a 2 or 3 hours long time surgery. You will use a lot of fluoroscopy, but you need a mentor with you, and you have to learn very well and to have a good formation. After 20 cases, you can have an upgrade of your surgery. You can use less fluoroscopy, and the triangulation will be more intuitive for you. And after 40 or 20 cases, you can be more comfortable, and you can begin to teach to the other people. For me, there is 3 skills to develop, and it's very important to know that, and it's very important to know what is your bad skill. First, you have to triangulate. It's your first skill. The second, you have to coordinate your camera with your instrument. You have to follow always your instruments with the camera. All the instruments has to be in the middle of the screen, and it's not the same like the triangulation. You have to work this coordination because sometimes it's very difficult. You are very concentrated on all the environment, and you forget to follow your instruments. And you have to be to have a good ability with your hand, right or left, depending of your dominant hand. The peers first triangulate. After, you have to have a clear field with a big working space at the beginning, and during your learning curve, you will reduce the size of your learning space. The bone is your GPS, but it's like this in each surgery in spine. You can and you have to record every case to have a debrief sometimes with your team. You will improve your technique and your speed. You have to check your ergonomy. You have to check always outflow. Soft is always better. You have to find a mentor, and you have to follow your involving in the surgery. This is a step-by-step technique. We can cut the technique in 6 steps for the stenosis. First, the incision and the dilatation. During the incision and dilatation, you begin to create a working space. You can see 20% of the surgery will be dedicated to the working space. After that, you will drill a lot, and the bone work is about 40% of the surgery, because you have to keep the yellow ligaments the more you can, because you will be safer. And you can see the hemostasis and the flavectomy is the same times, around 15%, and the closing. Don't check the minutes, because it will be the time you will do your surgery after your learning curve, but you will arrive at normal time, like in classic mini open or open surgery. For the herniated disc, you have a step more. You will drill less, but you can work the posterior wall, because you can retract your nerve, you can retract the dura, and you can work the posterior wall, because you have less bleeding with the pressure of the water, and we will see that after. For the beginning, the position is always the same. The portal placement is very important. We will see that. The working space, you have to create a big working space at the beginning, and after it will be less important. You have to find your anchors, lamina, ligamentum flavum, the facet, at each time before the beginning, and you have to open the flavum at the end and to decompress. We will see The free hanging abdomen is non-negotiable. You have to speak with your anesthesiologist. You have to target your blood pressure. You can keep your C-arm positioned because you can verify the level during the surgery. You have to confirm with the AP view, and you have to know and to manage the equipment for the irrigation. For the endoscope portal, it's a small incision. It's a bigger incision for the working portal. We will see after planning, a preoperative planning for the surgery, and it's important to have a preoperative planning because you will decide where you put your incisions, because it's not the same if you have a vertical or an horizontal lamina. And we will see the docking point. It's the most important point during the landmark. And we will see we always put some horizontal incision. For the working space, you have to create a big working space. I told you to identify the anatomical anchors, to decompress and close, and we will see all these steps. It's a prone position, and you will put 2 incisions. The most important is the orientation for me in your screen, and you have to imagine always the same orientation with a superlamina at your left part, the infralamina at your right part, the posterior joint and the spinal process. If you will be on the right part, you will have the mirror of this image. For me, we are 6 neurosurgeons in my institution, and we can do 100% of the spine diseases without instrumentation. But every lumbar and every cervical degenerative spine diseases, but maybe except tumor. But if I have time, I will show you we can do neurinoma and meningioma also, but it's triportal endoscopy because you can add another portal. For me, it's a popular technique, and I think I'm a popular surgeon because I don't need to choose the patient. I can propose to all my patients without instrumentation the endoscopy. And we spoke about uniportal or biportal, but I think it's the king's choice because when you speak about these 2 techniques, it's something very well and very good for your patients. For the good strategy, you have to develop a preoperative planning. If you stay at the left side or the right side, if you do an ipsilateral or contralateral approach, if you have incisions very medial or very lateral, the distance between the incisions, and after that, we saw that with Christoph, if you have an interlaminar or transforaminal or an extraforaminal approach. An example you can see on this CT scan, a big calcification of your yellow ligament and in the interlaminar space. And it's important you can also appreciate the depth between the skin and the spine, and the depth will define how distance you will put between the incision and the skin. It's very important to know this bone characteristic because you won't lose the motivation when you will drill, and you have to know how the bone is before the surgery. We'll speak about interlaminar approach. We saw there's different steps for the stenosis, for the herniectomy. The most important is the docking point. The docking point is the junction between the upper lamina and the spinal process. You have to triangulate on this anchor, this bone anchor. You can have some tip. I'm from Corsica, and I would like to speak about Napoleon because you can find this Napoleon hat in the interlaminar space, and you can imagine to have on the edge of the Napoleon hat this docking point. You have to focus on the docking point and focus for the triangulation with an AP view, and after that you can find your instruments with your camera and create your working space. I will just show you what we can do on the posterior wall. You can just, if you want to retract the nerve. You can remove, if you want, the disc, like you can do in Monoportal or Biportal or in mini open or open. It's a punch, normal punch with normal size from a classical box instrument. But after that, you can use, if you want, a hook. It's a hook with a bipolar cauterization. We'll see what we can do. If you want, you can use a hook like a dissector, because sometimes you can have some calcified herniated disc, and it's difficult because you have some fibrosis. You can retract the nerve, and you can do like a tumorectomy. You can do a debulking and use the hook to remove all around the calcified herniated disc, and to remove it, because sometimes it's very difficult. You use a punch, you use and reuse a punch, and it's difficult, and the result is not very good at the end. And you can use this hook to dissect and to debulk like a tumor, to do a tumorectomy. It's something it's impossible to do with mini open or open, because it's impossible sometimes to manage bleeding. And for that reason, you can put a retractor, and you can have less bleeding from the epidural vein. And you can do what you want with this kind of tool or another tool. And slowly you can go all around the calcified herniated disc and remove it. And it's something for me you can do with this kind of surgery, in endoscopic surgery, and you can remove progressively the calcified herniated disc, and you can have a free nerve. You can also, if you want, go inside the disc. If you have a big defect, you can reduce the parameters, but you know, sometimes you have big defect with big herniated disc, and you can enter in the disc with the probe. You can reduce the parameters of the RF. We know all of that because Christoph spoke about that. I just want to speak about some other tips. You can find also this kind of publication, and we have an ERAS protocol in our center, because the patient can arrive in the pre-surgery room with an hypnotized virtually glass. They come in the operating room. We always stand up the patient in the recovery room, and they can have discharge the day after and take the plane, because I'm from Corsica and I have a lot of patients from the island, and we have a follow-up with an app during 1 month, every 3 days, with a coordinatory nurse. You can have this kind of patient, but we'll see some other surgery. But you can, if you want, just do decompression, because if you have just claudication without low back pain with this young woman, and you can survey after this woman if you want to propose a fixation in 2, 3, 5, 10, or 15 years. But the more years you can win without instruments, the better it is for the patient. And it is something new with the endoscopy. You can find this kind of description with the butterfly challenge, because the ligamentum flavum seems a butterfly, and you can after see a lot of techniques with the ZN or W techniques. For the surgery, it's always the same. At the left part, the cranial part; at the right part, the caudal part. First, you have to create a big working space. This is an aggressive burr. It's a shaver with a protection. And first, you have to remove all the bone around the yellow ligament, and you have to keep the yellow ligament the more you can. After that, you have to find, this is the aggressive burr we told about. And after that, you have to find the cleft. The cleft is the midline, is a difference between the left part of the yellow ligament and the right part. When you can find this cleft, you know you are at the midline, and you can go in over the top to detach the yellow ligament, the right ligament to the right upper lamina to be an over-the-top technique and to discover all the yellow ligament. And you have to finish the bone work with a diamanted burr to go all around the yellow ligament, and after that you can remove safely the yellow ligament and to decompress and to see your dura. You can use at the end the kerrison. You can use also, if you want, the spatula, and we can also use some new tools we have now. Pneumodissector, it's like a hook, and you can just put some gaze, like you can see here. It's something new we do in our center. If you have an attachment and some fibrosis, you can create a space between two soft tissue, and after that you can enter in the space some instruments to have a good dissection. And after you can, I guess, also use the hook for the coagulation at the end to detach, and you can manage very well the detachment of the yellow ligament to decompress very safely your dura. This is lumbar stenosis. And at the end, you can do the hemostasis with the hook and with the thrombin. We also put always some bone wax, and at the end we can put some surgical snow. It's a surgical specific for the endoscopy. I will just go fast on these slides. We will speak about the bleeding. If you have a dural tear, you have just to put tacocil if you have a dural tear less than 1 centimeter. If you have more than 1 centimeter, you can do a suture and put tacocil. Sometimes if you are uncomfortable, you can convert. If you are lost in the patient, you can stop. You have to re-identify the lamina as anchor point. And you can, if you keep your fluoroscopy, to obtain a biplanar fluoroscopic confirmation. But if you can convert, but I don't like to say that. And the case selection at the beginning, single level lumbar disc herniation, L4, L5 better than L5, S1, because sometimes you have some very lateral S1 nerve root, not an obese patient, a soft contained disc if you can, an unilateral sciatica, and a standard bony anatomy if you can. The cases you have to avoid at the beginning: a revision surgery, an obese, a degenerative scoliosis, an highly migrated disc, a multi-level stenosis, and a previous fusion at the level if you have an adjacent segment. But you can do all these surgeries. At the beginning, it is your decision filter. You path forward. At the beginning, you can do the 21st cases single surgeries with herniated disc. You can, after that, do foraminal disc herniation, bilateral decompression. And after that, when you have more than 40 cases, you can do multi-level decompression, hydral disc migration, and lateral recess stenosis. And at the end, when you will be an expert, you can do UB TELIF, cervical UBE, thoracic decompression, and revision. You can have a roadmap like this, but you can define the roadmap you want with the time you want. I will give you some papers after. 3 things to remember. First, you have to be safety with the patient, and you have to operate maybe after 30 cases. You can see with some mentors. You have to be humble and to have a good formation and to ask for help when needed, because you will maybe save lives for that. And you have to check and to have, I think, a mentor. We spoke about that, and you will have the register slides. But what you will see at the beginning, you have to create an aquarium, to explore, to decompress, and to confirm that all the nerves are free. The ligamentum flavum, when you open the ligamentum flavum, everything changes. For the hemostasis, you have to check the irrigation to identify the bleeding. You can use a bipolar. You can use hemostatic agent. and you have to reduce also the blood pressure. Beyond the beginner, we saw that, but you can, after do UB TELIF, it's the next frontier. You can do cervical UB. Sorry, because I would like to present you, but I have not enough time. And at the end, and thanks to Christoph, because he spoke about that, but you have to have the adhesion of all your team. You have to train your scrub nurse. You have to speak with your anesthesiologist. You have to brief them. You have to educate all the staff. It's for that reason we standardized all our surgery and staying at the left side of the patient, because the installation is always the same and it's easier to have the adhesion of all the team and all the staff. If you can begin with some colleagues, if you can begin with a mentor, you have to do some debriefing with your mentor if you can, with the colleagues if you begin the formation with them, and you have to negotiate, and there is non-negotiable discussion with your institution and with the director, and you have to negotiate all the materials you want. Sorry, I was a little bit long. If you have any questions, I think we will speak about that now, my email, and we will be very happy to receive you in Bastia if you want, because we will spoke about the endoscopy, but also the generative surgery. Sorry for the time if I was long, Christoph and Thibault.
You were perfect, Joseph. It was really interesting, and you said everything that matters. So thank you very much for your presentation. Christoph had already responded to a lot of questions in the Q&A. So I don't know if there is any more questions.
The system tells me that I already responded to 21 questions.
Yeah.
But I mean, maybe somebody has a question here, you know, it's more interactive for everyone.
So, Christoph, just one question that I saw was coming a lot is when you have bony cloud from bony drilling, how do you manage it to have a feel less cloudy?
The bleeding from bone?
Yeah.
Okay. So first of all, I think when you see a bleeding, then you should attend to it, okay, and not continue, because then you have several bleedings and then makes it more and more difficult, okay? Bleedings from the bone, you can actually address many of these with a bipolar. You go straight there, and that actually solves a lot of the problems. And otherwise, what I do is I use the burr. I go straight to the bleeding, and I start the burr, and this actually seals the bleeding at that stage, okay? Otherwise, in the spinal canal, you can also use things like flow seal. You can use compression, for example, also. You put the dissector on the bleeding, and that will stop. So we have one of these teaching modules that I showed you towards the end of my presentation that focuses on how to deal with bleedings from soft tissues, from epidural vessels, from the bone. So maybe have a look at one of our YouTube videos.
Okay, there is another question here. So, if you have epidural lipomatosis, it's perfectly suitable for endoscopy. I think you don't have any problem, Joseph, to do it with the Biportal, and also Christoph with Monoportal. I know, but it's quite yeah, actually it's.
Yeah, maybe it's one of the easier indication, but it's really easy to do that.
Yeah. So it doesn't pose any problem. Yeah.
Thibault, I don't know. I think, you can do it.
Yeah.
I'm sure you can do it with a biportal, and you can do it with a microscope, and you can do it with uniportal. But I don't necessarily find that very comfortable sometimes, with a small instrument and then trying to take the fat tissue. So maybe a trick, what I would recommend, I sometimes like to, because sometimes the fat tissue in endoscopic surgery can be very coherent.
Mm-hmm.
And I find it easier when you first take like a dissector and you go through that fat tissue and you like take away these, you like basically break it down. And then it's easier to start resecting the fat tissue. But it's, I find that sometimes uncomfortable.
Maybe you can be more comfortable if you try Biportal.
I said it's technically possible.
A good indication for
but
Biportal.
also,
There is a question here about breaking instruments. So with Biportal, I think it's not frequent, but you can burr actually the scope if you work too closely from the scope, right?
No,
It
because
happens.
you can use some protected scope, and the shaver has also a protection, and it's very rare to break the scope with the shaver and
Joseph,
with the protected scope.
Joseph, it's rare, but it's possible. And with Uniportal, it's impossible to do that. So maybe you should try the Uniportal.
It's true, but
Just
we
joking.
spoke about. No, it's true, but we spoke
But
about that in our surgeon group. And I think if you have a bad equipment, it is possible, because at the beginning everybody want to begin very fast and they want to take the equipment in the room close to their room. And if you have the good equipment, it's impossible.
So technically speaking, with the Uniportal, it's impossible. Okay, because the burr is in line with the endoscope. There's no way you can't get around the corner too. So with the Uniportal system, this cannot happen.
And they have just a question about the conversion, but for me, the conversion is not acceptable at the beginning, because if you have a good formation and if you take time, if you block a big time for your first surgery, you have to take the time to do the good surgery. But you have to manage also your environment and the pressure of all the team, because you convert when you have a big pressure from the anesthesiologist, and you have to brief all the people before the first surgery, and you have to brief all the staff.
Maybe Thibault, just one thing. So to get back to this topic, you cannot break the lens with a burr, but if you use the bipolar and heat too close to the optics, then with a bipolar, then you can, in both Uniportal and Biportal. The bipolar is an issue when you use the bipolar when it gets too hot right around the lens. Yeah, if you use too short distance, but not with a burr. Was there a question I didn't understand? Was there a question about conversion, going back to open, for example? If not, I think this is a very important point. I think the most important thing is patient safety. So if you don't have the experience yet and you start a surgery and you feel like you are lost, that's when things maybe become more dangerous, okay? I personally recommend the most important thing is get a good result, have no complications in the beginning. If you have bad complications, your first 10 cases, you're probably never going to do it again. Okay, so I would always recommend rather convert, finish the surgery safely. The patient has no complication. I think that's very important. Okay, because the patient should not suffer from our learning curves. Very important.
Okay, good. So also one question for you, Dr. Siepe, regarding the different burrs that you can use during monoportal surgery. If you use diamond burr, aggressive burr, the size of the burr, how do you choose? Is it relevant or not?
I do almost everything. I don't work with a diamond burr. I have a medial protection, but my burr is not protected caudally because I actually use the tip of the burr. I showed you the burr in my video that I use. I don't use the diamond burr. for a number of reasons. It's a little bit slower. I don't necessarily find it safer. I can work very precisely with the other burr. So, but I mean, there's no right or wrong. You know, if you feel comfortable using the diamond burr, then you use the diamond burr.
And you don't
Sorry,
have
and
more
one more topic.
bleeding?
Sorry, Thibault, one more thing. Here for us, the diamond burr is not reusable. So you open it, you use it, you have to throw it away. So it makes it more expensive. Whereas my burr you can use over and over again until it's like blunt or it doesn't work properly anymore. Then you have to change it, because otherwise, if you use it too often, then you can actually break the burr because you will need too much pressure. Okay. But I very rarely use the diamond burr.
Okay.
But it's a good burr, so it's a matter of taste. You know, there's no right or wrong.
Joseph, there is a question about the fact that when you use UBE or even Monoportal, we basically work with only one hand because one hand is using the scope. And how do we manage to use the loss of one hand to operate?
In fact, in mini open or open, your non-dominant hand use always the suction.
Yeah.
But you don't need suction in endoscopic because you have water, and you don't need the second hand. First, second, you can use a retractor, and you can be helped by your nurse scrub, and I think we have a lot of options to have a second hand or a third hand, and we can do also triportal for the tumor.
Okay, thanks. So one question about operating under local anesthesia. It's possible, and I do it with Monoportal. So just local anesthesia for transforaminal and epidural anesthesia for interlaminar. I think it could be more difficult maybe with Biportal. I don't know,
No,
Joseph.
this are the same. We can, and we do every week.
Okay.
And the guy who do a lot of local anesthesia is François Le Chanoine in Italy.
Okay. How do you repair a dural tear in UBE, Joseph?
It depends the size of the dural tear. If you have less than 1 centimeter, you just put some tacosil. If you have more than 1 centimeter, even if you have some herniation of the nerve, you put just a suture or a dura clip, and after that you put the tacosil on the dura. You don't need bed rest, and you can stand up the patient in the recovery room, and we have no complication after that.
Okay. Okay, so maybe last question before we leave you. In UBE, how do you manage to clear the soft tissue at the beginning to have a clear field, Joseph?
Yeah, it is maybe the main point at the beginning, because it is endoscopy, and we would like to be to be very careful with the soft tissue. But at the beginning, with the dilatators, you have to detach with the dilatators the soft tissue from the bone, and you have to begin the creation of the working space with the dilatators. And after, the challenge is to see the lamina 7 seconds after the entry of the scope. And you will be available to do that maybe after 10 cases, but don't be careful about the dilatators and about the dissection with the dilatators before the working space, and you will win maybe 20 or 25 minutes at the beginning.
Okay. Okay, thank you guys. Thank you a lot to the two very good speakers for your time. Also, we will be there at the Edu Week in Strasbourg at the end of June. There are still 4 places remaining for the introductory course and 3 places for the advanced course. So if you're interested to go further in endoscopy, it's a very good place to start. Thank you for your time, and we'll see you soon, maybe in Corsica or in Strasbourg. Thank you, guys.
Thank you.
Thank you.
Bye-bye. Thanks
Bye.
a lot.
Bye-bye.
Thanks, Thibault.
Thank you, guys.